Good afternoon. Hello and welcome to our Cancer Survivorship panel, Embracing the Future. My name is Dr. Cheyenne Corbett, and I'm co-director of the Duke Cancer Institute Supportive Care and Survivorship Center and the Center for Oncoprimary Care. And we appreciate everyone joining us today for this Cancer Survivorship panel discussion. Survivorship Week is focused on highlighting our cancer support and survivorship services that are available to you and your loved ones throughout the cancer experience. Through our educational offerings and self-care activities, participants will enhance their physical and emotional well-being, improve their treatment experience, and build resilience for the challenges that they may face. Before we get started with our panel discussion and the introduction of our panelists, I have a few reminders about our webinar today. A reminder that today's webinar is being recorded. We do invite you to submit questions during the discussion today through the Q&A feature. We will do our best to answer your questions throughout the presentation. And if needed, a live transcript of this event is now available option and may be turned on or off by selecting the closed caption or live transcript option from the menu at the bottom of your screen. So I'm thrilled to be here for our 16th annual Survivorship Day celebration. Today, we honor survivors, we support individuals and families facing cancer, and hope to inspire those who are newly diagnosed. We also express our heartfelt gratitude to our many oncology team members, our faculty and staff, who continuously strive to deliver seamless, exceptional care to all of our patients and their families. Here at Duke, we have a long history of providing exceptional and comprehensive care. For over 50 years, we have been providing quality oncology services and leading research in the field. But more than just a timeline, it reminds us of our commitment to the continuity of cancer care for each individual patient and their families, with patient-centered care as our highest priority. This means our team works tirelessly to improve. It means creating a seamless intersection between community outreach, screening, and diagnosis, between coordination between our Duke primary care team and our Duke cancer care team, between our various specialists, including surgical, medical, radiation, transplant, and immunotherapy treatment teams, and between our cancer specialists in supportive care and survivorship, who all work together to provide services for patients, caregivers, and their families. And we do all of this with an intense focus on achieving cancer health equity while providing top quality cancer care to all of our patients and for our community. Today, we are joined by a talented team of clinicians. I ask each panelist to provide an introduction of themselves, sharing their name and their title, as well as their area of expertise. And so I'll start with Dr. Sundar Ramalingam.
Hi, thanks for having me today. So my name is Sundar Ramalingam. I'm a medical oncologist at Duke Raleigh Cancer Center. I specialize in genitourinary cancers, which are cancers of the kidney, prostate, bladder, and testicle. And I've been here at Duke Raleigh for about 8 years. I'm pretty much from North Carolina. I did my high school and middle school here, and I did my undergraduate at Duke and residency and fellowship at Duke. And, as a medical oncologist, we use medicines like chemotherapies and immune therapies and hormonal therapies to treat patients with cancer. I'm also the director of GU oncology for Duke at Wake County. So yeah, happy to be here today.
Thank you, Sundar. I think you're one of the only people I've met who grew up here, went to school here, and now continues to work here. It's pretty amazing the investment you've made in your community. It's very cool.
Thank you. Thank you. Happy to be here.
Dr. John Ragsdale.
Good afternoon, everyone. Yeah, my name is John Ragsdale. Wear a bunch of different hats, but currently I'm chief of the Division of Family Medicine outside oncology, and then I'm the vice chair for clinical services for my department. In this role, I am a primary care provider who sees patients that have cancer and have worked with the Cancer Center on helping roll out what that process and integration looks like between primary care and the Cancer Center. And I also see, along with some folks here in this window, we do survivorship work on the 5th floor for GU cancers in the same sort of area that Sundar works in, as a primary care provider who supports people that are going through either the front end, during, or after part of a cancer journey. And that's me.
Thanks, John. Kim Slauson.
Hey there, thanks so much for having me. Kim Slauson. I graduated from Marshall University in Huntington, West Virginia twice. I got my bachelor's from there, and then years later I went back and became a certified family nurse practitioner. My first job as a nurse practitioner was in oncology. Never thought I'd practice in oncology, but I fell in love with it. I fell in love with the kids that I worked with, and I was very passionate about survivorship at that point. Moved to North Carolina in July of 2017, and I took a position at the Preston Robert Tisch Brain Tumor Center here, and worked there until I saw a survivorship opening. In January of 2020, I transitioned and became the advanced practice provider. It's called APP, team lead for survivorship and clinical services. I work as a nurse practitioner in the survivorship and oncology space. The survivorship patients that we see, me especially, I see breast cancer survivors, prostate survivors, an occasional lung cancer survivor, childhood cancer survivors, Hodgkin's and other blood cancer survivors. We are an expanding team. Very much in the breast space. And I work with 2 excellent nurse practitioners in that. And then I'm also the team lead for tobacco and smoking cessation. Have a great team.
Thanks, Kim. You do have a great team. Lisa Massa.
Good morning, everyone. My name is Lisa Massa. I'm an assistant manager in the Department of Rehabilitation and a physical therapist by training. I graduated from the University of Pittsburgh 27 years ago. In addition to oncology, my other interest in clinical practice is women's health. So women's oncology holds a space near and dear to my heart. When I got here 27 years ago, I was asked to help build the oncology outpatient rehabilitation program, which just continues to grow and grow. I also oversee our our oncology residency program for physical therapists. So it's great to be with everyone today.
Thanks, Lisa. It's great to have you today. Paige Fisher-Strino.
Hi, everyone. I'm Paige Fisher-Strino. I am a clinical dietitian here at Duke, and I specialize in oncology. I've actually been oncology certified dietitian since 2011. I started at Duke in 2010 in our inpatient adult oncology units and also adult bone marrow transplant. In 2015, I transitioned over to Wake County, and I've been here since. And my primary patient population is breast, GYN cancers, GI, and some hematology oncology at our Cary clinics, and also thoracic.
Thank you, Paige. Dr. Kelly Highland.
Hi, everyone. It's great to have you here today. My name is Kelly Highland. I am a licensed clinical psychologist and a clinical researcher here at Duke. I've been at Duke since 2020 when I came to finish my medical psychology training, where I did most of my clinical work in the Cancer Patient Support Program. And I have stayed here since as a postdoc scholar. And most of my research is focused on developing and testing interventions to help to improve quality of life and health outcomes in cancer patients and survivors. And I have a particular interest in helping to address the emotional needs of the growing population of people living longer with metastatic cancer.
Thank you, Kelly. And Valerie Worthy.
Hello, everyone. I'm happy to be here. I'm Valerie Worthy. I'm a registered nurse, and I've been a registered nurse for 42 years. And in case you're counting, I graduated at 5 years old from nursing school. No, I'm just joking. But anyway, I'm also a 25-year breast cancer survivor and a patient navigator manager. And so it's just real near and dear to my heart to be able to navigate people, not only in our system, but in our community. So I'm really happy to be a part of this wonderful panel.
Thanks, Valerie. We're happy for you to join us today. So now we'll continue with the panel discussion, or begin the panel discussion. We've had some questions that have been submitted in advance, as well as some that we hope that you submit today while we are talking, as you have questions that come up for our team of experts on the call today. At the Duke Cancer Institute, for us, survivorship care encompasses the whole cancer continuum from the point of cancer screening and diagnosis, as well as through treatment, and life beyond cancer. And so this means our oncologists like Sundar collaborate with our primary care providers like John to ensure high quality, seamless care throughout that cancer continuum, covering everything, as I mentioned, from screening to diagnosis to treatment and survivorship. And this includes the management of late and long-term effects of cancer and its treatments. So I wanted to start off today by talking about this relationship, because I think this is something that we at Duke do that's fairly unique, but already showing an incredible impact on the care that we provide, is this relationship between our primary care providers and our cancer care team. So I'd like to start by talking about this relationship, and first have a question for John. As a primary care provider who's also been at Duke for just a couple years, can you talk about your collaboration that you've had with oncology? Because you've seen this from our inception of really being intentional about that collaboration, and what impact that's had on you as a primary care provider to have that collaboration and communication directly with the oncology team, and including specifically perhaps the survivorship team.
Yeah. So for me, before I was involved with this group, patients would get, when I would take care of people in other places where I worked, I was up at Brown before I came down here, patients would get cancer and they would sort of disappear down a rabbit hole for 5 years, and they would come back with a slew of new medical problems, a bunch of new medications, and really no clear pathway for me to move forward oftentimes. At Duke, it's an entirely different scenario. We've managed to set up a communication pathway, both through areas of research and working on papers and way to direct the network to how to treat certain cancers around screening and treatment. But also sort of as I work sort of both, I work in both places. I work in primary care and I work at the DCI weekly. It is amazing to me that we have a group of people where you'll have a GU group in a room with an oncologist, a medical oncologist, surgical oncologist, radiation oncologist, all talking about the best course of action for a patient, and then having that clearly transmitted and communicated across, so that I know as a primary care physician where things are going in a simple, clarified way. It's a completely different paradigm from what I came from, which is why I work over there.
Yeah, and one of the projects that you were involved with, and Kim, if you could also speak to this, is I'm thinking about that front end of the experience. We talk about diagnosis and screening. Our team, and when I say our team, folks in primary care, in urology, in oncology, worked to change the prostate cancer screening guidelines here at Duke, that led to some really incredible changes as it relates to our screening processes, as well as the referrals for follow-up care. But in doing so, we also saw that there was a lot of referrals being placed to urology, which became sort of very challenging to see that number of patients. Can you talk about the elevated PSA work that's happening, specifically the clinic, around how that's really helping patients get rapid access to care as well as high quality care? John, first from your perspective as a primary care provider with those new guidelines and making those referrals, and then Kim, if you could follow up with what that looks like in terms of your role with the EPSA clinic.
Yeah, so there was no clear pathway beforehand. So now there is. We've studied this and know that it brings more people into the practice, and realize we did see some disparities, both social and racial disparities in that work. So it became even more important that we create this pathway to get in. So now there really is a way, a simple way through referral to get people into the elevated PSA clinic where they can be seen in a timely fashion. So I'm going to pass that over to Kim to take her side of that.
Absolutely. And thank you so much, John. So whenever a primary care provider puts in a referral for elevated PSA, they have a choice. It's the PSA less than 10 or greater than 10. And if it is greater than 10, that's the higher the risk of prostate cancer. So those patients are usually streamlined in to see urology quicker. But those men that had PSA less than 10, they were starting to have a wait time of 4 to 6 months. And that's a long time to sort of wait and worry. Do I have prostate cancer? Do I not? Do I go someplace else that can see me sooner? So we started an elevated PSA clinic that Dr. Ragsdale's a part of, as well as me and the other nurse practitioner, Sherry Stewart, that works with us. And we see these men virtually if they can, so they don't have to come into the cancer center and have that stress. And we talk about their risk factors. We explain what PSA is, because it's a good test, not a great test. And then we further the workup. Do we repeat the blood test? Do we get an MRI? Do they need a biopsy? And since we started this in 2021, we've had about 15% of these men with a PSA less than 10 that have had clinically significant prostate cancer. Valerie helped us. We have a patient navigator specifically for African American men, because we're finding the disparities and they have some barriers to care. So to work with Melody to make sure that these men, understand and they get the follow-up that they need. This has really been a very helpful clinic to get these men seen sooner, or reassured that, hey, this is not a prostate cancer, that something else was irritating your prostate, causing that number to go up. So the clinic has been very successful and just keeps expanding.
Thanks, Kim and John. I think that's been a great example of the collaborations that have been happening in between the different groups and how we're changing care for patients. I'm sort of going to jump through, and we're going to come back to the treatment phase, but I'm going to jump to survivorship phase, sort of post-active treatment timelines. And Kim, with your work in the survivorship clinical services, this again is a very developing area of ours. Our team is growing. We're partnering very closely with our oncology clinicians like Sundar around how do we best provide care to patients when they're completed treatment, and what does that care team look like? And now between our survivorship clinicians, our primary care providers, and our oncologists, we can really utilize those different areas of expertise to really help with that whole person care during survivorship. So can you tell me a little bit more about that role in terms of the survivorship clinic and how you coordinate with folks like Sundar and John in terms of the care of patients?
Absolutely. Patients, whenever they finish their treatment, they still want to come into the cancer center. They feel very close to their oncology team because I've worked with them for several years. But the goal is to eventually get patients back to their primary care providers. So we like bridge that gap. If the patient is not quite ready to go back to primary care, they don't feel comfortable, then we see them and we sort of take the treatment that they received from medical, radiation, or surgical oncology, or a combination of the three, and we develop a care plan. We talk about their latent long-term effects, how to treat those, to understand those, making sure that they're plugged in with all of the supportive care services that they may need. Do they still need to quit smoking? All of the supportive care services that are still available to them. And then we talk about heart disease, diabetes, because it's likely not going to be cancer that comes back and takes their life. We have excellent ways to screen for and treat cancer. It's going to be heart disease or diabetes. So making sure that they understand the importance of that, and then communicating all of this to them, empowering them, and also letting the primary care provider know, like, hey, this is the treatment that they had. These are the things to watch out for. And we put it right at the top of the note. I work in a primary care setting, and we work closely with primary care providers. Like, what should our notes look like? What do you guys need to know? And just put it at the top. Don't make me scroll through, pages and pages of a note. Just put it right at the top. Like, what mammogram do they need? How often do they need screenings? And so we've had a lot of good feedback with primary care providers. But also, unfortunately, patients do have recurrence. So if that happens, getting them back into their oncology treating team, or if they were treated someplace else, getting them into, a team here at Duke to unfortunately treat that. But hopefully I get to see them in a few years whenever they treat it and they're successful and they're survivors.
Thanks, Kim. And Sundar, I wonder if, as an oncologist, then, if for the folks who you've been seeing who are now in that post-treatment phase of survivorship, what difference does it make for you in your clinical practice or your peers in oncology to have these partners to collaborate with you to provide that shared care for patients? And what difference do you see it makes for you as the provider, but also for your patients?
I think it makes a huge difference. Cancer is tough. The initial phase is difficult. They go through a lot of emotions, a lot of physical symptoms and side effects they may deal with. And, once they're done with that phase, we really need to be thinking about a lot of things. So one, I feel like it gives them some more expertise. When we're focused a lot on the actual treatment and sort of the immediate side effects and, really focused on trying to get them through that phase, that they need a team that can focus on, some of the long-term things in terms of cardiovascular health. What was mentioned, things like diabetes and heart disease. We need to continue to focus on surveillance. We need to also think about, other cancers and screening for other cancers and secondary cancers. And, that is best achieved with a team-based approach. And so I think when we put it all together and we've hit like kind of several points of this, starting from screening to treatment to survivorship. We always think survivorship starts from the first day of diagnosis, but in terms of, completing active treatment and working together, I think it goes a long way.
Thank you for that. And to your comments about like survivorship being from point of diagnosis or helping people lead their best lives as they're going through treatment, setting them up for the highest quality of care, being able to participate in their care. And then through survivorship, it's been a really important focus for our team. And it makes me think about some of the changes in the field that have happened over the last 10, 15 years. And I'd love for each of you to speak for a moment of what you've seen as like major advancements in your areas of expertise as it relates to our cancer care and the work that we're doing and sort of how it's really changing the face of how we're providing cancer care together. And I will start with Kelly.
Well, I'm gonna cheat and give a twofer. I think the first one is on the kind of drug development side. I think we've seen such incredible advances in targeted anti-cancer agents in the last 20 years, which are just amazing. But also more on kind of the palliative and supportive care side, we've also seen a massive expansion in these services and really kind of recognition of these as an essential part of quality cancer care.
Thank you. Yes, when I started at Duke, I'll just put my little 2 cents in. Over 20 years ago, the idea of talking to somebody about what the cancer experience was like for you or your family was still sort of not normalized in the way that it is now, right? And we know that cancer has this ripple effect into people's lives, their relationships, their sense of self. And for this team to be able to addressing this as evidenced by this panel, to me is also really exciting. And Kelly hits on what you were talking about of like one of the advancements in terms of being able to talk about these things and normalize things of like that impact that cancer has on your life. Kim, what are your thoughts?
I agree with Kelly. I mean, immunotherapy has just changed the game in treating, cancer. But I also feel like, we also have learned from the past and, we have limits to some of the medications that we give so that we don't like absolutely cause a patient to need a heart transplant because of the amount of adriamycin that was given, or, they've changed just the way things are treated so that, there's not a lot of radiation to the chest. I mean, it's just that whole, we're learning the late and long-term effects and trying to find better ways to treat so that patients don't have to deal with all of the side effects and everything and the supportive care services. I'm just hitting it all. Sorry.
Awesome. Thanks, Kim. Lisa, what about you? What are your thoughts?
I think from a rehabilitation perspective, the biggest thing I've seen over the last 2 decades is when I first started my career, we had this concept that cancer survivors were incredibly fragile and we shouldn't push them too hard or exercise too much because we'll they'll break a bone, they'll get horrible swelling, sometimes known as lymphedema, and we really shouldn't push. And actually, there's wonderful research to show that exercise not only benefits the person as far as their ability to function, but there are studies now showing that they have less rates of recurrence when they exercise at a high intensity. So I think that's super exciting for rehab professionals. I also think that the management of lymphedema has gotten much better in the last 20 years. The cases I used to see 20 some years ago, arms and legs were already pretty swollen by the time they came to physical therapy. And now, both through patients advocating for themselves and doctors advocating on their behalf, they're being seen much sooner. So it's much less of an issue, both cosmetically and functionally.
Thanks.
And I'll put up one other plug in. I think the other thing is, because this is near and dear to my heart, is that we are now communicating and talking much more about the sexual health issues of all of our cancer survivors. And I think that is a part of someone's quality of life that really matters. And I'm glad to see that we're having better, more open discussions about that.
Absolutely, Lisa. Thank you. Paige.
For me, it's been a big game changer when you have the multidisciplinary approach to the team component of care, because when a patient is coming in for that initial appointment with their family member, significant other, they're anticipating they're going to see the physician, they may see nurse practitioner, the PA, but now we have a more inclusive team. You have someone like myself, a registered dietitian, you may have physical therapy, occupational therapy, speech pathologist, is someone that's addressing any financial concerns, and someone that is addressing your psychosocial health. So we're really taking care of the whole patient so much better than we did that when I first started, just 15 years ago here at Duke. So I think that team approach is very helpful.
Thanks, Paige. Valerie, what are your thoughts about this?
So I guess I can speak through the lens of a patient and patient navigation as well. But I'm encouraged because, just as Lisa said, 20 plus years ago, no one asked survivors about sexual dysfunction. No one asked about our cognitive impairment. And those are things now that are almost third and fourth questions, which are really encouraging to patients. And then, of course, there's patient navigation, which has grown by leaps and bounds. And not only are we as nurses able to help guide our patients through making these critical decisions, making informed decisions, but also we're able now to connect them with resources, not only that are in the cancer center, but out in the community, and to bring their family and their friends as a part of the whole care team. So that's so encouraging to me, and I'm sure it'll continue to grow and grow and grow.
Thanks, Val. John, I'm curious your thoughts about this too, of the changes you've seen over the last 15, 10 years.
Well, I mean, first, we sort of slid over the idea that was said that, we worry most about diabetes and cardiovascular disease now in a large majority of cancer patients, so one is a surprise to, I think, a lot of primary care providers when you bring it up. If you ask them what would be the thing that would be the problem, many of us would not have guessed that at this point would be such a thing. And just owing to the increased survivability of many cancers as a result of the work that Sundar and others are doing. And two really gets back to this communication idea, which I cannot overemphasize enough, about being able to know where people are in their journey with care and getting good direction from the oncologist about what to do next. It makes, as a patient and a provider, knowing that everybody on the team knows what's going on easily with a patient and where they are on their journey, it's just transformative for me. Those are the main ones.
Thanks, John. And Sundar, what about you?
Yeah, there's just so much to that we could pick, and I'd probably expand a little bit on the immune therapy idea just to kind of get a little bit technical. I think immune therapy was mentioned before, but you think about, so immune therapy is a very broad term. So we also like to inform people that there's many different types of immune therapy and a lot of different research going on. We think about chemotherapy as, the drug that's been around for decades and decades, but, it works great in certain circumstances, but in other circumstances, it has more limited duration of response. And what we see with immune treatment is that we harness the body's own ability, the immune system's ability to recognize cancer. And when it can recognize cancer, then we can do less in terms of drugs and other treatments, because the immune system can take care of it, and can take care of it not only for the short term, but a lot of times for the long term, for cures, for long-term remissions. And I'll highlight a class of medicines called checkpoint inhibitors. And the research regarding checkpoint inhibitors led to a Nobel Prize given to two gentlemen, one out of Texas, and MD Anderson, and the other one from Japan in 2018. But these are drugs that a lot of our patients ask about. There's commercials for things like Opdivo and Yervoy and Keytruda, but our immune system has these checkpoints. They're like security centers that can actually identify cancer cells and kill them. And they're kind of like a custom stop, or like a security checkpoint. And cancer cells turn these off. And through research, these drugs have been able to turn these security centers back on, these checkpoints back on. And it's kind of a revolutionary approach. These drugs are now approved for many different cancers. And because they've been so successful, now we've been able to find similar drugs and expand upon the research and expand upon the prognosis and survival of cancer patients.
It is amazing to witness those clinical advances. And from a patient perspective, I know it can be so overwhelming. First of all, hearing the words that you might have cancer, and then receiving a diagnosis. And all these different treatment options are so hopeful for people. And at the same time, they're so complex, for people to understand and to make sense of and to make decisions about. And so Sundar, what are your thoughts then about informed decision making and how you talk to your patients about care? Because it is, again, so overwhelming, and at the same time, so many incredible advances. How do you walk them through that from a survivorship standpoint, as well as like a new diagnosis standpoint?
Sure, it's a lot. And when people are diagnosed, it kind of comes fast and furious. And not only does it come fast and furious as in terms of hearing the C word and hearing about the diagnosis, but you have a lot of information available to you through things like Google and the internet, and you have friends and family that offer advice. And it can be a lot to handle. And one thing that I try to emphasize to patients is that, one, it's really important. You want to be informed as possible, but you want to be careful in terms of where you're getting the information, how you're getting the information. So I tell them to, after the point that I meet them, I kind of tell them to, one thing is, it's always good to have a notepad during appointments. I feel like we cover so much that either the patient or a family member, it's good to take some notes and have something to refer to. And then try to really focus in on, the advice that we give and the advice that the multidisciplinary team gives. They will meet other people on the team, like nurses and other physicians, and try to focus the information and research on things that are communicated to them. And so try to stay informed, but try to take notes, and try to make sure we have good sources to kind of guide the information. So that would be number one. And then the second thing that I like to really focus in on is mental health, because we're really great at the physical symptoms and side effects and monitoring and the lab work, but it's really hard to understand all the emotions that are going through a person's mind. There's a lot of fear. There could be fears, there could be doubts, and it's really important to identify people around you, family members, or other support groups. We offer a lot of support with our nurses, navigators, and really for the patient, make sure you have somebody or something or some group that you can get some of your mental health taken care of, because in order to kind of fight it physically, you also need sort of that mental support. So those are a couple of things that I try to highlight.
Thank you. And Sundar, that second point you made, we have Kelly here on the call. Kelly, as a clinical psychologist and part of the Duke Cancer Patient Support Program team, what are your thoughts about that in terms of that emotional and relational impact that this cancer diagnosis and treatment has, as well as some strategies that you teach people to help them cope?
Yeah, I'm over here cheering. It's always so refreshing to hear medical oncologists kind of acknowledge the extensive emotional and mental health impact of cancer and its treatment. I am in the business of coping, so it's tough to kind of select one strategy. But I think it kind of first starts with awareness, right? And I think we're doing a better job now of asking people about kind of how they're feeling and what's going on mentally and emotionally. But it really starts with us being able to kind of like identify how we're feeling. One thing I always kind of reinforce to people, and I think we all can benefit from, is just like the power of a pause and a deep breath, right? So I think that Sundar hit on kind of the range of emotions that we can experience during cancer diagnosis, treatment, and survivorship. And it can feel really overwhelming with all of that information and all of those different emotions. And it can cause a lot of anxiety and distress, right? And so the next time you feel overwhelmed, I recommend just kind of like stopping, right? Maybe you put a hand on your chest or on your belly and really focus on slowing down and taking some deep breaths, because this can send a signal to your brain that you're okay and can actually kind of help you slow down physiologically. So you might not be able to control all the stuff going on around you, but you do have the ability to kind of control how you respond.
Thank you. That's really helpful. Lisa, I want to ask you a question based on some that are coming through. You know, I think people hear they know physical therapists and sort of think about what they do, but can you talk about onc rehab and what your role is like in oncology, and specifically about how your team first addresses things like physical activity and exercise and the benefits of that to people during survivorship, and how your team does that?
Sure. So in the outpatient world here within Duke Health, we presently have 3 cancer centers, and we do have physical therapists at each of the locations, so they can be seen on site while they're getting treatment. But then also, we presently have 19 clinics across all 3 counties, Orange, Wake, and Durham, that have physical therapists at them who are able to address long-term survivor issues. So some of the big things that we hear a lot from our survivors at different phases of their survivorship is, you know, my cancer's well maintained, I'm doing well from that end, but I just don't have the same energy. I can't do the things I really enjoyed doing before I was diagnosed. And it may come down to some weakness and deconditioning or fear if it was a more intensive, physically intensive thing they enjoyed doing, like half marathons or doing really challenging hikes in Western North Carolina. And they're like, well, can I still do these things? And so we often try to create exercise programs, whether in a clinical space or things they can do on their own at home, that can help them get back to those activities that they really enjoy. The other thing that's wonderful to see for a lot of our survivors is they're becoming grandparents, and they want to be able to chase around a 2-year-old, you know, and so, you know, grandma doesn't look like she can't hang. And so we often come up with ways that they can interact with their kids, even if they do have, you know, some mobility restrictions. The other thing that we address often is education and strategies to prevent and or reduce any swelling, or otherwise known as lymphedema. And that is a combination usually of specific manual techniques that the therapist can do in the clinic, teaching patients how to wrap their arms and or finding the right garments for their arms or legs, so they can prevent the recurrence of swelling. And then, as I mentioned before, the other thing that we ask a lot about is sexual health, and is the physical sexual is their physical sexual health where they want it to be? What do they feel they're not able to engage in? Do they have any anxiety concerns about re-engaging in physical intimacy? And if so, what that might be. And we do that in a multidisciplinary way with our clinical psychologists, medical family therapists, physical therapists, and medical oncologists. So we often ask a lot about that. In addition to sexual health, we also check in on bowel and bladder function, because certain tumor types, unfortunately, that can be a challenge based on the treatment that they've had to receive to manage their cancer. So we kind of try to look at all the aspects of your physical body and what you want your body to be able to do, and then try and come up with a plan that's tailored to that specific person to help them achieve their goals. That's going to make their life, allow them to have the greatest quality of life possible post-diagnosis.
Thank you. And I think you mentioned at the beginning, like how some of the things that have changed, that you are now getting referrals earlier from people and not later and more reactive when there's a major problem in terms of side effects or late effects. And I know there's sort of a term going around too that's called prehab and things like that. Are there things that your team recommend, or of course it would have to be personalized and you can meet with people, but that people can start doing as they're starting their treatment that sort of helps them set themselves up for the treatment itself, but also their survivorship, and how that might help make things easier or better for them physically?
Yeah, so you're right. It definitely depends on the individual and the particular cancer that they're facing. But I think, assessing your own physical activity level and diet intake are two great places to start. And the other big one that we talk a lot about is sleep. How well are you sleeping? Do you have a lot of problems with your sleep? Because sleep is so, so important to our overall health. So those are things that people can kind of reflect on, like where they might see potential for improvement. I agree to your point too, that it's never too soon to come see and talk to us. And that's one of the reasons we try to also, in addition to the multiple clinics Duke Health has in the outpatient world for rehabilitation, that we also embed physical therapists in our cancer centers. So we're always there to have a chat if you have a question. And I think there's probably three places to start globally. And then, the other thing I always encourage patients to do is advocate to their physicians for a referral. I have yet to run across the oncologist who refuses to send a referral for physical therapy. So I think they're pretty amenable to that. So just ask and we'll be happy to interact with you in any way you think would be beneficial to them.
Thanks, Lisa. And Paige, I imagine that's the same with you and the other oncology dietitians, the sort of the timeliness of when you connect with people. What are the types of, education you provide to people about diet and nutrition during survivorship phase, of what those key points are for them?
So this is one of the aspects, I think, after diagnosis. So cancer diagnosis is, it's shocking, it's overwhelming, and you can't control what your treatment is going to be. You can't control that timeline. And so oftentimes patients go out searching for, what have I done wrong? Oh my gosh, I drank alcohol. I used to drink a lot of sodas, I eat sweets, fast food. And so it's often this blame that they put on themselves unnecessarily. And then also you have your supportive community around you, and they also don't have any control about what your treatment plan is going to be, but they know somebody that knew somebody that knew somebody that had your cancer, and everybody's going to give you a little piece of information. So I always, when I initially meet with someone or message someone, I say, please, take everything with a grain of salt. And if it's overwhelming, tell people in your community, your family, your loved ones, that it is overwhelming and there's a lot of bad information on the internet. So Dr. Google is not always providing the best. And I always encourage people to go to reputable resources that provide them with quality evidence-based answers. So an easy way to find that would be find information from an NCCN cancer institution, that's the National Comprehensive Cancer Network, which is nccn.org. Any of those cancer centers are going to provide information that may not be available on our Duke website. That is going to be excellent information for you.
That's great. And you and your colleagues are such an incredible resource for people during treatment as well as after treatment, to help them sort of take in that information. And you guys really work with them in a really personalized fashion to help make, meaningful changes in their lives, but answer their questions. Because as you said, there's so much misinformation out there. That oftentimes when people are going through cancer diagnosis, treatment, survivorship, as you said, they're sort of reaching for things that they can do, that they can control. And it's important that it is things that will be helpful to them, which is really why we have these team members in place in our supportive care and survivorship center to really help you, our audience and our patients with what are those tools and resources that can help you through, and who are your people who you can rely on that information, the quality of information that you're getting, and then how to make these changes in a meaningful way in your life. So it doesn't become one more thing that's sort of this overarching heavy weight that people have to sort of think through.
And we are really fortunate in the Duke network, my colleagues, different dietitians. So just like Kim and John touched on, you know, oftentimes with survivorship, I'm more concerned with your heart health, your metabolic health. So you can talk to a dietitian that specializes in diabetes or in weight loss counseling. So we have resources that are specific to the person's survivorship needs.
Right. Thank you. And Valerie, as I think about sort of the complexity of that and the different team members involved in patients' care, a lot of patients, you know, again, this can be an overwhelming experience for them. They might have a lot of questions. They might have various barriers to care depending on their access to our cancer center, other factors in their lives. Can you talk about how the navigators specifically help people as part of those steps in their care?
Absolutely. And thank you for that question, Cheyenne. So what we try to do as navigators first is to find out from the patient, what is your goal in this care? You know, and some will say, I want to see my teenager graduate. I want to see, you know, my son or daughter get married. And then we work from there to ask, so now what's your best? How do you learn best? Is it videos? Is it just having this conversation? Is it talk back? What is it? And then we can relay those messages to the primary team. And then we ask, because, you know, in these visits, we have, as a survivor, we have 10, 15 questions. So we help them to determine what are the most important questions, the top 3 that you have. And then later on, as you continue your meetings, you can infuse some of the other questions, but what are the top 3 questions that you have? And then we ask them, what would prevent you from making your appointment? Do you have transportation issues? Do you have support care, social support in your community, in your family? Do you have someone that can come alongside you? Because believe me, you will forget everything that they told you. So have someone to come alongside you, just as Dr. Sundar said, someone that can write the notes, and then know who the people are in your life. Some people will tell you stories about somebody that they heard that had cancer. Take that with a grain of salt. But you have other people that really want to help you. They want to give you a gift or make you soup or just be your cheerleader. But understand who they are in your life. And then with this team that you already have in the cancer center, you also have a team out in your community. And we gather all of that information and we look at it and we look to determine if there are any gaps. And where there are gaps, we take the resources that we have inside of our cancer center and plug them into there. If there are gaps out in the community, we do that same thing, so that we believe that we provide a holistic plan and support for that individual. And then, of course, we always tell them that they can call us, they can call a nurse. We all work as a team, and that when they can't get in contact with someone, then maybe we can help them do that, so that all of their attention isn't focused on trying to make this connection, but on trying to heal. So that's just a few things that we do as navigators.
Thank you, Val. That's so important. Kelly, we see a lot, there's a question coming through about the impact of cancer on somebody's relationship. So there's a participant who's mentioned that they've been out of treatment for about 6 months, and mood has recently been down and starting to see an impact on relationships, including marriage. What are your thoughts about specifically advice for this person or resources that are available to help them?
Yeah, I'm sorry to hear that. I also think it's such an important point to bring up, that the effects of treatment often don't end with treatment, right? And so many people experience effects post-treatment, whether it be physical or emotional or mental. I think this person has already in some ways done the toughest thing, which is kind of like recognize how they're feeling and how it's impacting them and the people around them, which is really brave in and of itself. And we are super fortunate at DCI to have really wonderful resources to help with kind of this exact issue. So we have the Duke Cancer Patient Support Program, which provides psychosocial services to cancer survivors and families, no matter where they are in the cancer trajectory. And amazingly, these services are free of charge. And so this team is comprised of people like medical family therapists and psychologists who really specialize in working with patients and their families on kind of issues just like this. If there are kiddos, we also have services specifically for them. So we have child life specialists and some programs where, you know, they might be able to help you figure out how to best talk to your kiddos or actually talk to your kiddos with you. These services can also be delivered virtually, which I think is really great, especially if you're not coming back into the cancer center regularly. And these services, you can get a referral from your provider, or you can kind of reach out directly via our website. Maybe we can put the link to the psychosocial support services in the chat.
Thanks. And Kelly and Sundar, perhaps, and maybe even Kim, part of that question I think is important too, in that, you know, everybody, there's sort of this thought, especially with like family members or the community around a patient, that when you get to the survivorship phase, everything's going to be rainbows and unicorns and everything. But there's still that sort of sometimes angst or worry or, you know, concern that people are experiencing, especially as they're also not coming every week for appointments perhaps, or getting their blood tested frequently. And so there's also this sort of dichotomy of like happiness and joy of being in that phase, but also that, you know, worry or, you know, I think the person said sort of a down mood. And I know you guys see that in your practice. And Sundar, what are your thoughts about that and when you see that, and how Kelly and colleagues can help support you and your patients during that time frame?
Yeah, you know, it's really tough because, you know, there's not an easy solution to that. I think, you know, we at least when I talk to them in clinic, I try to get them to try to talk through the scenarios of what could happen. And by doing that, you know, sometimes I can lead them to a path where, you know, for instance, you know, I see a lot of patients with prostate cancer, and they are always worried about their PSA levels. And so, you know, I kind of try to paint a path, a couple of different paths for them, to tell them, you know, if it comes up a little bit, this is what we're going to do. If it doesn't come up, then this is what we're going to do. And if it comes up, these are the things that we can do to treat it. And, you know, these are the options that we'll have. And, you know, when you kind of give them hope that no matter what the outcome of the test is that they're anxious about, that we're there to kind of help support them, it does help to kind of reduce some of their anxiety. And you know, just on a level of, you know, this is how I deal with it in clinic, that's what I try to do, which is have kind of open discussion and let them think through the possibilities and see how we can support them. And we always want to bring in the incredible staff we have. So we would always refer to others to help them with the mental health and processing of this information. And, you know, despite everything we do, sometimes they continue to have a lot of anxiety. Patients, you know, the night before the scan, I see that, you know, frequently, even today, a patient can't sleep the night before a scan. And I think the more dialogue we can have with them, and the more we can kind of tell them that we're there to support them regardless of the outcomes, then I think that's, you know, the thing that we can do to help relieve some of that stress.
That's a great point. Kelly, can you add to that? What are some specific resources that you and your team have to help with that sort of anxiety at those times, but also even things like sleep?
Yeah, totally. Actually, what Sundar just described has a little name as a skill in psychology. It's called coping ahead, right? So like we know that emotionally and physically challenging circumstances are going to come up. And oftentimes we are kind of skewed towards thinking about the worst possible outcome, right? So we spend all night maybe thinking about what's going to happen if that scan comes back and it doesn't look good. But what we don't often open ourselves up to are the other possibilities, right? Maybe it's neutral. Maybe it's totally fine. And so Sundar is like gold star medical oncologist for helping people think through these beforehand. But this is also something that we might be able to do ourselves, right? To kind of think about all of those different outcomes and then actually imagine ourselves dealing with each of those situations, right? Because let's say the worst case scenario happens, it's gonna suck no matter what, but we're probably gonna be able to handle it, right? And we have this great team behind us to be able to manage it. If it's not the worst case scenario, great, right? Maybe we actually plan to kind of celebrate that, right? So there's lots of kind of different skills that we teach patients so they can do some self-management, right? I think the night before the scan example is a great space, right? So like, there's probably not much we can do the night before a scan that's going to change the outcome, right? And so maybe we can kind of acknowledge that and instead say, you know, I know I'm going to feel anxious, but what's something I can do to distract myself so that I can just kind of make it through, right? Maybe I plan to watch this Netflix series. Maybe I talk to somebody that I love, right? So there's lots of different strategies that we can kind of empower patients to use to help to manage some of those things.
Thank you for that. We have a few minutes left, and so I encourage anybody who has any additional questions, please go ahead and submit those to the Q&A just for any final thoughts. And John, while we're waiting for those to come through, if I'm thinking about our audience today on this panel or anybody else who might be thinking about this, if somebody doesn't already have sort of that reconnection with their primary care provider in survivorship or even during their treatment, you mentioned that sometimes when they start treatment, they sort of disappear for 5 years from you as a primary care provider and then come back with all this information and change. So much has happened to them during that time. If they haven't already either engaged in communication or visits with their primary care provider during that time or haven't yet re-engaged with you, what advice would you have for people who are in that survivorship phase or approaching it of how and when to reconnect with their primary care provider and why that's important?
I think ideally you should never lose contact with your primary care provider through this process would be the ideal situation. But if you have, call them, reconnect. I think the background of that is, what do you need to have from your primary care physician that looks like a trusting relationship in this new phase? So, you know, have that dialogue with the provider when you reconnect. You know, explain to them what your and hopefully they'll be asking you about what your new needs are, what are your concerns, so the things that we can address in the visit. But I guess the first thing, you have to pick up the phone and engage, because they do want to see you, and they will want to help bridge you back into the primary care relationship if that has sort of fallen out, which can happen during care. But they do want to see you back, and they do want to help you with your journey, you know, forward, is what I would say.
Thank you, John. And as we're wrapping up, I'm curious, from each of your perspective in your respective fields, what is one thing you would tell a person who's just learned that they have cancer, and what would be important for them during this experience? And I'll start with Paige.
So when it comes to nutrition and diet, anything that I would tell you as a survivor is the same thing I would tell any other adult. Like, what is important for your heart, what is important for your metabolic health, what is important for preventing cancer or cancer recurrence. These are all very similar recommendations, and they're all very balanced and straightforward. There's really nothing sexy about it, and it's not anything that a cool influencer is going to tell you. So, you know, look out, you know, there's well-balanced recommendations that you can accommodate in your life. And there's a lot of great resources. Reach out to your oncology team to get introduced to your oncology dietitian or a dietitian in your community.
Great advice, Paige. Lisa?
I think from a physical therapy perspective, I would say is don't let cancer dictate what you think your body is capable of during treatment and after. And don't, you know, if there's something you want to accomplish in any of the physical activities or daily activities or recreational activities that matter to you, you know, ask for a referral, because I think all things are usually possible. So I would encourage people just to seek information and not let cancer dictate their long-term goals for their life.
Thank you, Lisa. Kim?
One of the big things that I see with patients in the survivorship phase is they tend to question the decisions that they made, like, why did I have this surgery instead of that or whatever? And I always just tell them that, you know, like Sundar said, bring somebody with you that can help, you know, process all the information, take the notes, and realize that you made the best decision that you could given the information that you were provided at the time. We don't know if 2 years from now we're going to find a cure for whatever cancer or a different medication, but making the best decision and feeling like that's their decision, not their husband's decision or, you know, what else, but the best decision for them at the time, given the information that they're provided.
Yeah.
And being happy with that.
Thanks, Kim. Kelly?
Yeah, I think this kind of piggybacks a little on what Lisa said, but I think one thing that's so important is just to continue to do things that bring you joy. And a reminder that you can experience grief and sadness and also still experience joy. Don't kind of, you know, not let yourself have that just because you're feeling sad or scared. And kind of as Lisa said, if there are barriers or if there's ways that you need to get creative, there might be resources that can help you to kind of access those things, even if they look a little different than they used to. So do those things regularly.
Thanks, Kelly. Sundar?
I guess broadly speaking, I would say that just take time to think about your goals, like what, because we'll have options for different scenarios for patients, and I feel like a lot of times it's helpful to just kind of process the information and really analyze like what are the most important things, and maybe even write them down and discuss it with your provider. And so that way, you know, that, you know, the treatment and approach can be tailored to a patient's needs, because, you know, sometimes we make a lot of assumptions on what patients want and need. And I think really spending time to think about it and communicate it is very important in this process.
Thank you. That is very important. Great point. And John?
Yeah, think about what a trusting relationship with your provider looks like, and see if you can embody that when you go see them. As Sundar said and others, if questions are bubbling up consistently for you, try to write them down, because you're admittedly you're gonna forget them when you get into your, you know, time in front of the provider. So just know that those are probably the two most important things, along with bringing in a friend, which I have heard other people say, which I think is just critical if that works for you.
Thank you. And Val, you're always my go-to for closing thoughts. What's your one thought of what you would tell somebody?
So as a cancer survivor, I'd say, even though cancer, the diagnosis is scary, it's not a medical emergency. And so find the time to find those people that can support you both inside the cancer center. You know, look for the medical family therapist, look for the navigator, look for physical therapy, look for dietitian. You may not need any of this at the moment, but find them, get the telephone numbers so that when you need them, you can access them. And similarly, in your community, find those resources that can support you as well.
Thank you, Val. And thank you to all of our panelists today for sharing your knowledge and your experiences. You guys are incredible colleagues to work with, and I so appreciate you sharing with our audience today. I encourage everybody to take advantage of the remaining offerings through our Survivorship Day. Today, we have on-site and virtual activities, as well as through the week. The recordings will also be available on our Survivorship Day website after this Friday. And remember that our services are available to you and your family members through the suspicion of cancer, through diagnosis, treatment, and survivorship. Our team is here to support you. For information about our support services, you can visit dukecancerinstitute.org/supportive care. And again, thank you everybody for joining us today. Take care.